Now let me tell you about diabetes and bariatric surgery. It's a hot topic, and we need to understand. When we started bariatric surgery, we were concerned about weight loss surgery, but then we discovered that it has an impact on diabetes and eradicates diabetes. So for example, the Stampede trial showed that if you take medical therapy, your chance of being off treatment when you have started with an HbA1c of 9 and above, your chance is 5% to not to require any treatment after 3 years. And at 5 years, it's only 2%. Compare that to 38% in a bypass and 24% in a sleeve after 3 years versus 29% and 23% after 5 years. Those results encouraged many people to say, well, it seems bariatric surgery is more effective as a therapy for curing diabetes. So here we're talking about patients who are off medication and with an HbA1c below 6, so they're cured. The rest, probably 90%, were in the range of 6 to 7 HbA1c, so they were protected from the harmful effects of diabetes, but they were not cured. And then people said, okay, so what is the right procedure? Should we say just RYGP is the right procedure based on these facts? So if you look at this curve, this is comparing a sleeve and gastric bypass. If you look at baseline versus at 6 months, you'll find that if you do a gastric bypass, your chance of being on no medication is 45%. While in a sleeve, your chance of being on no medication is 25%. So gastric bypass has a higher effect than sleeve in cure from diabetes. But then at what expense? That was an issue that people were discussing. So let me share with you in this study, when they looked at Stampede, they wanted to look at the comparison between surgery and medication, and they wanted to look at them as in terms of BMI. So those who were BMI 35 and above, and those who were below 35 BMI, and they found that surgery has a better effect on higher BMI, but even in the low BMI, it was superior to medical therapy. So even if the BMI was low, it was superior to medical therapy. And that brought us to the change in the NIH guidelines of 1992. The first change was done in 2015, and basically said we should consider bariatric surgery for diabetics with a BMI of 30 to 35. That was the first change. So we recommend it for those above 35, but for 30 to 35, we should consider it. So it was a softer indication, but that was the beginning. And in fact, we saw a move to class 1 obesity BMI 30 to 35, where we said, okay, Ali Amini wrote the paper and basically said, well, BMI 30 to 35, they should have bariatric surgery because the evidence is overwhelming and the procedure has become safer than before. And we started showing people the issue with the hormonal impact of the procedure, the change in insulin, change in GLP-1, change in ghrelin, etc., depending on the procedure. And this is a demonstration of how bariatric surgery really alters hormones. This is the insulin secretion related to glucose level. So after surgery, the slope of the curve increases in sleeve and in bypass. So the pancreatic response to hyperglycemia is better. And in fact, in RYGP, it's not only better, but it starts a much earlier time. So at a glucose of 5.5, you start seeing insulin, while usually you see it at 6.5. Also, the other point that you see is the slope is uphill. So there is almost a 2 or 3-fold increase in the secretion from the pancreas at 4 weeks from surgery. And that tells you that bariatric surgery is effective in releasing insulin from the pancreas, not only making the insulin work better. And hence, bypass has a much superior effect on the release or on the secretion of insulin from the pancreas, and hence common sense would say, okay, so any diabetic should have RYGB, but then we have looked at the literature and found that this is not really true. There are other reasons. So why would RYGB have a much more effect than a sleeve? And the answer was in the GLP-1. You can see in GLP-1 release in RYGB, it's almost double that of a sleeve. You can see the GLP-1 peak. And also, we have seen the insulin secretion is higher in RYGB, to tell you. And if you look at the curves, if you give someone oral intake of sugar, you will see a rise in GLP-1. If you give them that sugar in the IV, you will not see a rise. So that tells you that this rise is because when you rerouted the food in the intestine, that resulted in a raise of the GLP-1. So why would that happen? And here is the curve that tells you. So basically, when the nutrients reach the latter part of the intestine, in the figure on the left, that is the gastric bypass, that resulted in stimulating certain cells that usually don't see food, because usually the food is absorbed in the upper intestine. So when the food reached the lower intestine, it stimulated cells that are usually not stimulated, called endocrine L cells, to secrete GLP-1, and hence that was the reason why bypass, because there is bypass, you push the food towards the latter part of the intestine, that caused the GLP-1 to increase. That effect was proven to be sustainable, which is sustained, and hence the effect on diabetes, even up to 7 years, was documented by Karkolos. Now, all the studies insist that a sleeve is effective because it does drop the hemoglobin A1C by almost one point, while in RYGB it drops it by 1.5 points almost. So still, bypass is more effective. Yet, with that understanding, then we'd expect BPD, which drops the food to the last part of the intestine, to be more effective, even if that is true. And that is true. In fact, if you look at the HbA1c after RYGB, it drops to 6 from 7.7 in a study by Bengron, but BPD would drops it to 5, almost to hypoglycemic level. And hence, it is a stronger procedure. And yes, it will have better cure for diabetes than RYG, but the harm that it does makes it not desirable by most patients and by most physicians and most surgeons, because it carries a higher risk, so it's not worth as when you evaluate the risk and benefit ratio. Here, it's a complicated slide, but I'll take you through the conclusions in blue. So the first study was looking at basically if you do a sleeve on patients, do they get remission from diabetes? And the long-term remission in sleeve patients was 61% in a study by Switzer on that. So I basically said, well, maybe we don't need bypass because bypass is a strong procedure. So people start saying, so which patients we should do sleeve and which patients should we do bypass? So if you go to the study on its right, so there was long-term control in almost 56% of patients at 5 years and 100% in the first year. So the results are self-explanatory that sleeve might be enough as a procedure in most patients, but who are the patients who would need bypass? And in fact, the study on the bottom left tells you that. It tells you as BMI increase, the difference between the procedures reduces, and weight gain explains a high relapse in sleep, but it is effective. So if the weight loss is sustained, there will be the same effect in high BMI. But in low BMI, that is not true. So we see the difference between RYGB and sleep, where RYGB becomes better in the low BMI only. So in the high BMI, they're almost equal in effect. And here we can see that. So Chevalier did a study and said in BMI above 35, RYGB is not superior. And in fact, the following studies below, Akramuddin, Shah, Liang, and Lee, said low BMI bypass is probably superior to a vertical sleeve gastrectomy. Also, one of the things that people always debate is, so how can you predict? What do you need to predict? And one of the studies that was done by Vijay Lee from Hong Kong, and he basically said, if your C-peptide level is below 3, you're unlikely to recover. If your C-peptide is above 6, you're likely to recover with a sleeve. So you need a functioning pancreas in a sleep patient, and hence this is why only in the high BMI sleeve is effective. Why? Because in the high BMI we think their pancreas is secreting, but it's not enough for their weight. While in the low BMI, because they're low BMI, we think their pancreas is the reason they're failing. So we expect their C-peptide to be low, and hence they will not respond as well. And then if you look at the Lee on the right side, he basically said bariatric surgery is less effective, but still it's effective in low BMI. And also on the left bottom corner, you can see bypass surgery has higher incretin effect in low BMI. So all about the same point. And then one of the what I call the prognostic scoring systems is what is called the ABCD on the bottom right corner: age, BMI, C-peptide, and duration. It's called ABCD score. So this is basically said older patients, low BMI, low C-peptide, and a long duration of diabetes, they're unlikely to recover. So this was the first start of introducing scoring systems. Then came other systems which we'll talk about as well. But we have to understand before we go into the scoring systems that long-term control, we'll talk about long-term control, which is HbA1c. So HbA1c is the amount of glycosylated hemoglobin, which means how much sugar is carried by the hemoglobin. So when the RBC is synthesized, it usually carries a certain amount of glucose in it, so it's called glycosylated hemoglobin. The amount of hemoglobin that has glucose in it tells you how bad is the diabetes. The more it carries it, the worse it is, and hence it reflects the situation 3 months ago. So it's usually the RBC's age is 80 days before they get destroyed, up to 120 days. So that tells you how was the control at the time of synthesizing this RBC 90 days ago. While day-to-day variation is another important issue that we need to understand. So when your pancreas is highly effective and secretes insulin and you've stimulated it, then there is a chance that when you eat and you stimulate, you may get a higher insulin response, and then you may get hypoglycemia, which is the other end of the spectrum. So day-to-day variation is something that we talk about, and this is what we call what I call hypoglycemia or neuroglycopenia that happens as a result of doing bypass or a sleeve. It's more common in bypass because it's a stronger procedure. Hence, we have to know in which patient should we not overshoot and get them to become hypoglycemic, because we want to cure them. want to improve their HbA1c, want to improve their diabetes, but at the same time, we don't want them to go to hypoglycemia. And on the right side, I'm showing you a diagram of a patient who had a glucose of 52, 53, 48. So all the time, this patient was having hypoglycemia. And even if you say, well, his HbA1c is 6, so he's cured, this patient is suffering because he's getting hypoglycemia frequently. And this is why, by wearing a gadget called continuous glucose monitoring, or CGM, and we're seeing that he's not doing well. So hence, it's just like the coyote and the roadrunner. You don't want to overshoot, you want to catch him only. And hence, when you look at all the scoring system, this is an example of the scoring systems that exist today. ABCD we just talked about. And then there is something called DIREM score, which has a score related to age, HbA1c, the pre-op insulin, the number of medication to use, and it's a score between 0 and 22. And then there were many modifications developed. So the DIREM or DRS is another computer system that was developed. It's a 19-point score and tells you the remission per procedure. And then there is the IMS score, which was developed by Ali Aminian, in which he took HbA1c, took duration of illness, preoperative insulin use, a number of medications, and made a score out of 197 points to suggest the procedure based on the score. I'll tell you, none of these scores is a validated, accurate score. It is basically best intelligent guess. Someone would predict what a score should be based on some statistical formulation in a limited group of patients, and would say, this is what I think a score should be, and I'd like everybody to use it. And I'll just show you an example of how scoring systems are, when they're done by surgeons, they're not done in the correct manner. So for example, this is the DIREM score calculator. You enter those figures, you can go on the tools and play with it. I am showing you a link to it. And basically, I'm just going to skip and say, so it gives you a probability. So if you score 2, then your sleeve gastrectomy will cure you in 83%, and Roux-en-Y will cure you in 100%. So it tells you, in mild cases, bypass superior. Then it tells you sleeve is better in the moderate cases, in the middle. So if your score is 14, sleeve will give you a cure of 39%, while RYGB will give you a cure of 29%. And then give you a score, for example, in the severe cases, it tells you that bypass is superior. So in the middle, it's not superior. In both extremes, it is superior, bypass superior. And that, in fact, is because they've made the scoring so 0 to 5, and then 6 to 10, 11 to 15, 16 to 19. And if you look at the scoring between sleeve and bypass, so whether you score 6, 7, 8, 9, 10, it will be the same, which doesn't make sense. So it is basically, they categorized it and gave an absolute number. So sleeve is only superior in 11 to 15. No scoring system should be this way, categorical, and be able to give you that. But it is basically someone's intelligent guess that gave the scoring system. A similar scoring system was made by Ali Aminian, in which he used medications and the use of insulin and the duration of diabetes and HbA1c, and said, well, those 4 predictors will give you a score. So if your score is less than 25, which means that you're mildly diabetic, then he suggested bypass. And then if your score is moderate up to 95, he still recommended bypass. And if your score is above 95, he recommended the sleeve on the basis that you're unlikely to recover in both procedures. So you can see on the right side, when it was mild, the chance of cure by RYGB is higher by 15%, and in the moderate, chance of cure was double. In the bypass, and in the severe there was no chance of cure, and hence This was the reason why he suggested, well, sleeve is a milder procedure, so do it. In fact, nobody was able to demonstrate his facts, and when we applied it to our patient, we saw that majority of our patients would have bypassed, though majority of our patients who had a sleeve were cured. Thank you.